Good evening, everyone. Welcome to another series of HCAH Educational Series. Today, we will be discussing about a progressive disorder, जो बढ़ता जाता है, which restricts the movement of the body. Parkinson's, as it is known in medical language. People लोग बहुत बार बोलते हैं कि मेरे पेरेंट्स, ग्रैंड पेरेंट्स expressionless होते जा रहे हैं. We can't see their expressions much. Is it normal? Are they sad? Or is it the starting of Parkinson's? Or road down the tedious path? Well, let's learn more about Parkinson's and movement disorders from Dr. Wadia. We have today with us a very renowned neurologist from Mumbai, Dr. Pettarusp Wadia. He's a graduate and postgraduate from BJ Medical College, Pune, and did his DM from Topiwala National Medical College, Mumbai. Post that, he got trained in Toronto for doing his fellowship in movement disorders at Toronto at University of Toronto. He also has various publications to his credit, and his areas of interest, as you obviously know, is movement disorders, botulinum toxin therapy, and deep brain stimulation. I welcome you, Dr. Wadia.
Good evening. Good evening, Gaurav. Thank you for inviting me.
So we'll start with maybe Parkinson's, and our viewers have patients in their homes who are getting treated, not getting treated. So could you just tell us what is Parkinson's?
So Parkinson's is a brain disease. It's a neurodegenerative disease. So basically, there are various aspects. The one that everyone knows about is the movement aspect. So it causes four cardinal features. One is tremor, which everyone knows, but tremor is really seen in only 30% of the people. Slowness of movement is what characterizes Parkinson's. So your movements become slow. You take long to button your clothes, dress, eat, do a lot of things, even walk. सब कुछ slow हो जाता है. The third aspect is stiffness in the body. And the fourth aspect is balance and gait problems. So gait and balance involvements. This is the movement side. This is the side everyone seems to know. But apart from movement, there's also a lot of other features in Parkinson's. And mainly that includes memory impairment, sleep impairment, non-motor features like constipation, urinary issues, sleep issues where you shout, talk, and sleep, called as REM sleep behavior disorder. So it's not just movement. It is lots more than that. And I think that's what we need to be aware of.
And how does it happen? What goes wrong? Is it an external factor or an internal factor? I remember at one point of time, the textbook used to say that it happens by drinking well water also. कुएं का पानी पीने से भी हो जाता है. But how does it happen?
So I think the very simplest answer is nobody knows. So what we believe is it's a mix of genes, so abnormal genes, probably with environmental factors. But really, if you look at single genes, the identification of single gene is only in about 5% of the Parkinson population. That too, when you're talking about young onset Parkinson's. So we really don't know. In fact, there's a large study, lot of what is called genome-wide assay studies going around the world, and there's a large one going on in India. We are a center at Jaslok too. So a lot of studies looking at trying to understand what causes Parkinson's, but till today we don't have everything. What we do know is that there is a trigger which causes deposition of a protein called alpha-synuclein in the cells of the brain, and because of which the cells that normally would have produced dopamine start dying or start reducing in number, and that's why you get Parkinson's.
Right. And you told us that there are movement related issues and there are memory related issues, right? But largely, as you said, what we observe is morely movement related issues, and at times these are very confusing, right? So what is the time when the family should take cognizance of these things? What are those small early detection signs where the family should take cognizance and seek medical help?
So basically, anybody who has, so if you have a tremor, if you become slow, that's when you need to take cognizance of it. And if you become very stiff, basically don't just attribute things to he's growing old and that's why he's become slow. People just don't get slow as they grow older. So just old age and brushing it off is, I think, the biggest mistake, and that's what delays the diagnosis in most cases. So I think you have to seek medical attention if something is not right, if you're not walking, if your speed is affected, if your walking is affected, if you're falling, if your balance is affected, if your speech is affected, if you're having tremors, you have to seek medical attention.
Right. And once the patient comes to the doctor, are there any tests which needs to be done and before you start the
So
treatment?
the diagnosis of Parkinson's is a clinical diagnosis where you take a detailed history, you examine the patient, and then you come to the conclusion, yes, I think it's the beginning of Parkinson's. And that's when you start treatment. So it is a clinical diagnosis. It is not, it is, there are certain tests, like you can do an F-DOPA PET scan or a TRODAT scan, which can help you in your diagnosis, but that is required in a very minority of the population. In the majority of the population, it is seeing the patient, examining the patient that tells you, yes, you got the onset of Parkinson's disease.
So there is no imaging required, there is no blood test required.
You require the imaging to rule out other causes. It's not for the diagnosis, but it is to exclude other causes that can look like Parkinson's. And that too, in a very clear cut case, you probably won't need it.
And just for the sake of our viewers, it's very, as you said, it's a clinical diagnosis, so it's very, very important to go to the right doctor. So can you tell our viewers that what is a movement disorder specialist, because you have done your fellowship from Canada in that. What does a movement disorder specialist does, and how it is different from a normal doctor or a general physician or a MD medicine?
So basically, movement disorders is a branch of neurology wherein it's a subspecialization within neurology where we are training in Parkinson's and care of patients with Parkinson's and other movement disorders like tremor, dystonia, chorea, etc. But I think movement disorder specialists form like all of 100 to 200 doctors across India, which is a very small number. So everyone may not be able to reach a movement disorder specialist because of lack of availability, but at least you must see a neurologist, which is now hopefully available at every district headquarter, at least most district headquarters, let's put it this way. So you have to see a neurologist, that's for sure. You cannot go to your family doctor and expect that he's going to solve all problems for you.
Right. So graduation, post graduation, super specialization, and then subspecialization. Well,
That's
that's quite a journey. So once diagnosed, what would be the for and in a very layman language, what would be the treatment of patients, and what are the latest modalities available? Is it curable? Because as we have heard, it is very chronic. It progresses. Can we do some surgery or something that it gets cured?
so there is no cure for Parkinson's. So we have three different levels of treatment. One is, first of all, there is physical exercise, which everybody needs to do. And in the initial phase, it is just normal physical exercise that a normal person does. If the Parkinson gets worse and your walking is quite affected, then physiotherapy programs help in a big way, especially gait balance training. Apart from the exercise and the non-pharmacological treatments, then we have drugs. The main focus of drugs is what is called as dopamine replacement therapy. We can use either dopamine agonists or tablets that are levodopa and similar drugs like that. In the initial phase, drugs are enough, and in the right doses, drugs can make you completely all right and keep you well for at least the first 5, 6 to 10 years. And later on in time, what happens, the drugs are working, they're working very well. But what happens is, as the number of dopamine cells in the brain reduces, the duration of that good period when the drug is working starts reducing. So initially it may be 5 hours and it'll go down to 4, 3, maybe even 2 or even less. So what happens is you develop what is called as on-off fluctuation. So on is when your effect of the medicine is very good. Off is when the effect of the medicine is not there, and then all your Parkinson's symptoms are visible. You might have a tremor, you might not be able to walk. Some people's offs are so bad that they can't get out of the bed, they can't walk, they're just lying in bed until they get their next dose effect. Over a period of time, what happens is during the on phase, you get what is an overdose phenomena called dyskinesia. So then you on phase, you're rocking, and in the off phase, you're like a statue, you can't move. So that's called as motor fluctuations with dyskinesias. Now that is quite a miserable state to be in. And that's when we have to look at options beyond medications if medications is not solving the problem. And the options beyond medications are three. There is dopamine pumps. So you get a duodopa pump, which we don't have in India yet. It's an intestinal pump where you have to put the drug through an intestinal pump. It's an intestinal gel, not available in India. And if you're able to manage to even source it from abroad, it's fairly expensive. The second option is an apomorphine pump, which is where you give subcutaneous injections of apomorphine in the stomach, and that helps you control the Parkinson symptoms well. The third option is deep brain stimulation. Deep brain stimulation is where you to put two wires in the brain, and you're giving electrical stimulation to patients with Parkinson's disease. And all three of these modalities, whether it's duodopa, apomorphine, or DBS, all of them significantly improve your symptoms to the extent of about 50 to 60%. It's not a cure, but it is a major improvement in the state that you were in prior to opted for any of these three treatments. Each one has their own side effect profile, their own risks, but you've got to be willing to do it.
Sure, but are these therapies only required once the medication effects wane off, or you can do it earlier also?
So there is a concept of early stimulation. Early stimulation is where at the very start of the on-off fluctuations, you do it, and you start DBS early. But you've also got to realize that these procedures have risks. So a risk of a DBS is 1 to 2% risk of brain hemorrhage, so which could make you worse than what you started out with. So unless you really need a procedure, you shouldn't do it.
Okay.
But at the same time, if not everybody is eligible for DBS. You shouldn't have significant memory problems. You should have clear-cut Parkinson's and none of the other diseases that look like Parkinson's. So it's not a decision that can be just taken overnight that I want DBS, and you have to be eligible for DBS. And so it's a lot of discussion that goes into it before you take a procedure like this.
Sure. So in the first 15 minutes of our chat, we have around 60 people live, around 250 people reached, around 20 shares of this video already. So it's picking up pace. We have been talking a lot of this hormone called dopamine, right? A neurohormone, right? You said that the medication is also to enhance it. The pumps are also to increase it, right? So what does this dopamine do?
So dopamine is a neurotransmitter, which basically is got two important circuitries. One circuitry is the movement. So it increases your speed of movement. So if you have less of dopamine, you become very slow. You have more of dopamine, you become good. And if you've got excess of dopamine, then you're rocking like this, and that's called dyskinesias. While on the other hand, it also plays a role in another circuitry, and the other circuitry is the reward circuitry. So if you have excessive dopamine, you can gamble, you can be shopping, you can have compulsive eating, and that's a big and worrisome side effect of a group of drugs called the dopamine agonists. So dopamine is required for both these circuitries. So it's also required for your. So it's the mood circuitry, the reward circuitry, as well as your movement circuitry.
Right, and it's also is it the same neurotransmitter which is called as a happiness hormone?
Yeah, no, that's sertraline. That's that's serotonin.
Okay, and so largely what I've understood is that if you have got it, you have to live with medicines, you have to live a life and still be productive. So what are your tips on telling our viewers that if they have somebody in their family who has got Parkinson's, what are the challenges of the patient, of the family, and how to live life with Parkinson's?
There are a lot of challenges, and the challenges are different at different ages. The young onset challenges is to hold on to their job without their employer realizing that you've got Parkinson's, because you don't want them to hold your promotion, hold your career path growth, especially if you're working well enough. Why should they judge you based on your disease? They should judge you based on performance, which I think would be fair for anybody. So that's the young onset challenges. So they're pretty different to the challenges of the older population. So we literally, I mean, the young onset patients, we literally need to handhold and walk them through life, ensure that we are taking the right medical decisions. And I always tell them, never leave your job until, even if you feel that your job is not working out because of your disease and you're becoming too slow, don't quit. First, come to us. Let us see what can we do next for your disease, rather than quit your job. Go on medical leave if it comes to it. Let us first readjust your doses, get you all right. Because once you quit a job, it's very difficult to get one back, especially with a disease. So that's the first thing. So that's the young onset lot. The challenges for the older lot is not to fall, to ensure that you don't fracture your limb. It's more about safety. So that's where, and that's where there's a lot of role of physical therapy that helps them to get the confidence to walk, to move, and of course the right of dosing and therapy.
Right. And what are the challenges for the family?
The challenges for the family is to ensure that you don't allow them to get depressed because of the disease, to deal with some of the complications. Like if you suddenly start compulsively gambling or shopping, the family has to be like alert as ever to realize that, oh, something is wrong behaviorally and we need to get to the doctor. So we usually on the first consult itself discuss all this with the family, ensure that if the family hasn't come, we meet the family the second time or the third time, if not the second time. We discuss all these issues so that the family is fully aware. In the older lot, the family needs to be the caregiver. There's also caregiver burnout that sinks in after being caregiver for so long. And then sometimes the drugs and the disease cause quite a lot of other issues. You can hallucinate. You can be seeing things, hearing voices. Sometimes they get hallucinations where they suspect their spouse is conspiring against them also, which is quite a horrible thing, because I mean your spouse may be you're with you for the last 40 years, and why would your spouse ever conspire against you? But these are hallucinations and we have to deal with them. We have to counsel the spouse. So you get a lot of caregiver burnout, frustration, and because the caregivers 24 hours with the patients, the caregivers have no break. They have not had a vacation either. So it's quite a challenge. And I think a lot of help is required to deal with them. And I think that's where organizations like you can come into place to make lives of Parkinson patients better.
Right. But before we step through that, how we can help, uh, you mentioned that the young onset Parkinson's is a big challenge, right? When do you say it is young onset Parkinson's, and a working person, when should he seek medical attention?
So young onset Parkinson is a small group of patients who have Parkinson's disease starting between 20 and 40. And I've had patients who've like graduated or post-graduated and like they're ready for a job and suddenly they get diagnosed. So I've had surgeons who are diagnosed literally on the day that they've finished their post-graduation and surgery, and that's horrible.
Yes, absolutely. So how do you think that a multidisciplinary rehabilitation team in sync with the treating doctor can add value? What is the role of that team? What are the value adds that team can give to these patients so that they lead a better and productive life?
So basically there's a lot that goes into it. The young onset people need a lot of psychological help, because the first question is, why me? मुझे क्यों हो गया? Why have I been singled out? मुझे क्यों अन्याय हुआ है? And there's no answer to that. I mean, the disease chose you. You didn't choose the disease, and you got to live with it. So there's a lot of psychological counseling that goes into at the initial phase to accept the diagnosis, then accepting the diagnosis, dealing with the diagnosis, dealing with the problems that the disease poses. Then there's a lot of sometimes marital issues that can come in, especially with some of these issues that can come. It's so you can, along with the compulsive gambling, hypersexuality is seen in men. So that can pose its own challenges. So the young onset lot need a lot of psychological help, a lot of emotional help, and of course they need to continue physical exercise. But they really don't need too much of physiotherapy support as much as the older population need. So the young onset people need a lot of psychological, emotional support. The older population, on the other hand, need more of the rehab support. They need physiotherapy, occupational therapy. Sometimes they may need a caregiver, and of course they also need the emotional support because many of them are lonely, alone, having to face a disease. So they need it, but they need it in different context.
So fall is one of the major side effects, or I would say comorbidities, which is
Right.
associated with this, right? Do you even advise a change in the home environment, or changes in where environment of the patient, which will lead to fall prevention?
So we do a lot of things for fall prevention. For fall prevention, you have to first look at the biggest concern is to adjust the doses so that to understand whether the fall is occurring in the off state or the on state. Your entire treatment has to change. So you have to reduce the off time or the on time depending on what is causing the fall. Whether there is postural instability, try to address that. The third thing to do would be if there is so all these issues you need to address. You need to do check for orthostatic hypotension, and if there is drop in blood pressure on standing, that needs to be addressed because orthostatic hypotension is a common cause of falls. Then we need to look into the home environment as to what is causing the falls. Is there something at home that needs to be addressed? Is there carpets or something that in the home environment that needs to be addressed? So, and then of course, you get a physical rehab person into the equation. An occupation therapist can also help. So yes, it is multidisciplinary. Fall prevention is not just something so small and so simple.
So usually in your practice, what we have also seen is that people would choose a caregiver to be with the person, to take him to the bathroom or outside, and then there would be a physiotherapist which will be coming. People largely don't know what is the role of an occupational therapist. Can you elaborate on that, please?
So an occupational therapist is something that's very underutilized in India, and I think also in short supply, both. So an occupational therapist is somebody who actually looks at the home environment, ensures that your home environment is safe and friendly in case you were to fall. So they give you all the tips on how to make your house safer and to do that. They also actually work a lot on hand functioning. They also work on cognitive functioning. So that's the role of an occupational therapist. And it's not physiotherapist or occupation therapist. It is physiotherapist and occupation therapist which you need. So they have to actually work as a team, not in silos.
Right. And so there is now this concept of a physiatrist also, right? And then there is a speech therapist also, right? Do you see any role of these two people also in this overall treatment?
So the speech therapist, yes, because we need a lot of speech therapy. So we need them to. So there's a lot. So the speech therapist has three roles. One is there's a lot of drooling, so they help in teaching them tricks to swallow your saliva. Second is as the disease advances, swallowing becomes a challenge. So they need to do swallow therapy because otherwise you'll end up with aspiration pneumonia. And the third role is to increase the voice because the voice becomes very soft. So you have to do what is called as Lee Silverman voice therapy to project your voice to ensure that the voice is heard much better.
Right, right. And beyond DBS and these therapies, right? Uh, you said there is something called Parkinson's-like disorders also, right?
Right.
What are those disorders?
So, so there are other neurodegenerative disorders that can look like Parkinson's. The commonest one being progressive supranuclear palsy or PSP. The second one being multiple system atrophy or MSA, and the third one being corticobasal syndrome or CBS, and the fourth one being dementia Lewy body, which is actually very similar to Parkinson's disease but with a lot of dementia and dementia coming in very early. Now, all of them are, if you had to choose between them, Parkinson's would be the better choice, because all of these are more troublesome, more disabling than Parkinson's disease. The drug of choice is still the dopamine group of drugs, mainly levodopa, carbidopa. So it's not that the treatment very much differs, but your overall quality of life differs, your prognosis differs. In PSP, you tend to fall, you tend to lose balance. You might land up in a wheelchair much earlier than you would land up in Parkinson's disease. And similar for MSA. MSA has other issues where you land up with autonomic dysfunction. You can have drops in blood pressure on standing. You can have urinary issues. So that's all. MSA. Corticobasal syndrome will come with hand the posturing. So each one has their own challenges, but the challenges are much worse than what Parkinson poses for you. Deep brain stimulation is not an option for any of the other Parkinson group diseases. It's only for those who have typical Parkinson disease.
And why is that, sir? Why DBS is only for what happens in DBS?
You don't respond.
You don't respond.
And it's not an approved therapy for any of the other diseases.
So, given so much of life becoming unproductive, and what is the average life duration of a person who's living with Parkinson's?
So the Sydney Multi-Center study, which was done about 10 years ago, literally tracked patients from diagnosis until death. And the average life expectancy of a patient whose Parkinson's at an average age, which is say between 40 and 60, 65 onset, is about 23.2 years, which is not small, which is a fairly long life. So the life expectancy is probably slightly lower than the average population, but not alarmingly less. So you can have a reasonable life with Parkinson's. For the young onset lot, it's even longer.
And it will be the same in India also?
I think it should be the same because this study was done almost 20, 30 years ago. And the treatments that we have for Parkinson's have gone up in leaps and bounds. And we have all kinds of therapies available now in India. So I'm assuming it would be similar, or if not better now.
Right.
Depending on whether you have access to the therapy.
Yes. So you even mentioned that there is this memory issues, and then there is one subset which loses memory early. How do we look after the memory issues of these patients? What do we help them with?
So that is a challenge. But we do have a set of drugs called cholinesterase inhibitors. So donepezil, rivastigmine. We also have drugs which work on the NMDA system called memantine. All of these drugs do help to a certain extent to improve memory in patients with Parkinson's disease. And they improve actually much more than what you get with Alzheimer's. So some of them can have a huge improvement on these drugs, but obviously it's not a sustained improvement, and eventually they will have a fair amount of memory issues, and memory issues become a big challenge because that really drops your quality of life.
Right. And any non-pharmacological or non-drug measures which we need to take?
So there are cognitive therapies. So there's a lot of cognitive rehab which can be done. Again, a psychologist has to pitch in and help out here. But I mean, it helps to an extent, obviously.
Sure. So we have already reached to more than 1,000 people and 120 shares of this video. And at any given point of time, we have had more than 50 people live. I think it was a very lucid and simple way of expressing such a complex disorder. So I'll conclude this educational series here only. Thanks for your time. Thanks. I know you are a very busy movement disorder specialist. Thank you so much for your time, and thank you for being with us.
Thank you. Thank you.
Thank you.